Hello, this is Dr. Turkmani, and this is an interesting case of anterior segment reconstruction. Patient that presents to casualty with corneal perforation of unknown cause, presumably herpetic, and a subluxation of the lens. It is unclear whether there is a torn posterior capsule with vitreous prolapsing in the anterior chamber. One of our trainees performed a glue patch, but as you can see, the glue patch fell off, so I'm trying to reform the anterior chamber using viscoelastics. I have the feel that it was possibly the posterior capsule bulging under the lens towards the perforation plug in it rather than vitreous, but what I'm not so sure is whether behind the optic of the IOL there was still posterior capsule or not. So I decided that I would reposition that lens in the sulcus, given that it's a one piece rigid PMMA lens. And since those lenses, if entirely in the sulcus, have a tendency to subluxate through the zonules, I would perform optic capture so the lens would remain centered and stable. So first I'm prolapsing the haptics into anterior chamber, and then very gently I'm going to reposition the haptics in the sulcus and perform optic capture. Of course, the eye was very soft because of the perforation, and there was some kind of vitreous pressure. There were large choroidal detachments in fundoscopy, so I'm trying to perform all these initial steps through very small incisions to avoid the risk of any expulsive hemorrhage. And when this is achieved, the next step is to perform a tectonic DSEK. Of course, I do not want to perform a penetrating keratoplasty with such large choroidals due to the risk of expulsive hemorrhage. So now I'm inserting there a manually dissected DSEK lenticle, but the lenticle was not unfolding properly because the AC remained very shallow, and in fact at some point it just turned upside down and I wasn't able to reposition it. So the second time I decided I would introduce it with a micrograsper, first take it out and then put it back again in with a micrograsper, and this second time thankfully the graft was in the correct position. Then I sutured them in port, did a further air tamponade and repositioned the graft as per my usual DSEK technique with pinpoint touches with a yellow needle in the endothelial side, but those pinpoint touches are not harmful for the endothelium. And when the graft was in the desired position, I did also in the end a glue patch. So just in case there was a graft detachment, I wouldn't have again a leak and a very shallow anterior chamber. The graft would at least remain attached where the glue patch is. Thankfully, it remained attached all the way around, and the patient is evolving satisfactorily. Thank you very much for your attention.